Hello, everybody. Good morning, good afternoon, and good evening to all. My name is Awad Mataria, and I'm the Director of Universal Health Coverage and Health Systems at the WHO Regional Office for the Eastern Mediterranean based in Cairo, Egypt. On behalf of WHO EMRO and the two co-hosts of today's session, USAID and the Asian Development Bank, I would like to welcome you all to this second episode of the series of webinars which are being organized as part of the 11th Asia Pacific Action Alliance for Human Resources for Health webinar series 2020. We know that the rapid increase in the number of cases related to COVID and their geographic spread has created enormous demand and stress on health systems and health workers worldwide. Health workers are at the forefront of the response to COVID-19, both as service providers and as high-risk groups for contracting the disease. The rapidly increasing workload has resulted in shortages in health workforce in general and in certain specialties in particular, such as intensive care units, physicians, nurses, infectious diseases specialists, pulmonologists, respiratory therapists, laboratory professionals, and more, in addition to the field of epidemiologists and public health specialists who are involved in the public health response. Today's session will be our second episode focusing on mobilizing surge capacity of healthcare workers in response to COVID-19 pandemic. In the previous session, which took place last week, discussion focused on mobilizing surge capacities for public health actions. In today's episode, we shall focus on capacities for diagnostic and clinical management. We shall hence focus on various human resources for health categories, including physicians, nurses, and midwives, but also pharmacists, laboratory technicians, and others. The main question which we shall address is the following. What additional measures are introduced by countries, including financial and non-financial incentives, to ensure the surge in capacity of diagnostic and clinical cadre? What are the encountered challenges, and what are the recommended effective solutions for those challenges? To answer this question, we shall be listening to various countries' experiences from different parts of the world. We hope that this experience sharing will allow all of us to distill lessons for the future on better human resources for health management towards universal health coverage and health security. Let me now hand it over to our great moderator, Dr. Eduardo Banzan. Dr. Banzan is the Principal Health Specialist in Sustainable Development and Climate Change at the Asian Development Bank. Dodo, the floor is yours.
Thank you, Awad. And well, more than that, always proud to say that I used to be with the EMRO as Regional Advisor for Health Financing. And in a sense, our first speaker, we will be having three speakers who will be talking about how they have built up surge capacity in addressing the clinical needs of COVID-19. This will complement last week's presentation webinar, which focused on public health. But expect a lot of, in a sense, overlap because as we understand, as you work on the ground, the building up the surge capacity can be done for both more or less simultaneously. We will be having three countries that will be presented. The first one will be a presentation from the Islamic Republic of Iran. Our presenter is a dear friend, former colleague in EMRO, Dr. Mohamed Asai. Dr. Mohamed Asai is now the advisor to the Minister of Public Health Affairs, Ministry of Health and Medical Education of Iran, which he has joined after he has retired from the WHO as WHO representative for Pakistan. He was also coordinator of integrated health services and regional advisor for primary healthcare for 13 years in EMRO. The second presentation will be done by Dr. Anwar Hamdani, Director of Tertiary Care Services of the Ministry of Health, Sri Lanka. Dr. Hamdani is a doctor. He also has a degree in business administration. He has been working in the Ministry of Health. He has been running hospitals. He has been director for medical innovation technologies in the Ministry of Health. And he's also a researcher. So Dr. Amdani will bring to us a range of perspective on how to build up the surge capacity in clinical care. Our third country will be the People's Republic of China, where we will have Dr. Shang Junhua, Director General of the Health Human Resource Development Center of the National Health Commission of China, who will be talking about how China has scaled up its surge capacity in handling COVID-19. He's also a medical doctor and finished his doctorate degree from the University of Sydney School of Medicine. Dr. Shang has also built a program in Tsinghua University on quality advanced research and studies. Finally, after our three countries, our commentator is the former Minister of Health of the Philippines and former Director of WHO Human Resources for Health Department, Dr. Manolat Dari. He has just retired as Dean of the Ateneo School of Medicine. He is currently the President of the Association of Philippine Medical Colleges and continues to teach, of course, in Ateneo. As they present, we would like everyone to please ask your question in the Q&A. We will not be having the participants, and we're now with nearly 200. You will not be asking the questions directly, but your questions, as they are written up in the Q&A, they will be then consolidated and asked from the from our panelists and commentator. So as you listen to the presentation, please start. And if you want to ask the question to a particular country or speaker, just put it in the Q&A. We will now begin by having Asai. Asai, you have the floor.
Thank you very much, Ludo. Thank you very much, Awad, Gulin, and all friends. Let me start with my first slide. And before that, I would like to appreciate the organizers for having such a timely webinar, and wish you all the luck. The national strategies I would like to share with you in combating the COVID-19. The whole government, whole society, community active engagement in different areas, a very active and positive intersectoral collaboration all over the country, and equity on delivery of the health services to the patients suffering from COVID-19 and their relatives. On the right side of the slide, you can see the capacity of testing, which is now around 25,000 tests per day. Of course, we have increased the number of the laboratories in the country, and now over 130 laboratories are ready to do the tests. On the left down side, you can see the number of the death cases that social gatherings and all the different events, especially the New Year of Iranian, which was 21st March, has increased the number of the death. And now, according to 19th August, we have 153 deaths on 19th August, with around more than 2,000 new cases detected. And totally, we have around more than 350,000 confirmed cases. On the right side down, you can see the number of the hospitalized and outpatient cases in Iran, which has increased recently, but again, it's going on gradually. In this slide, I try to show the strong health system with a special emphasis on primary health care. As you can see, it starts with our health houses. We have around 32,000 health workers. Name is Behbaz, which is known to everyone, and they were actively engaged in screening and contact tracing. In the urban area, we have health posts run by more than 24,000 family health workers, experts, and also we have urban health centers and rural health centers. We have identified in this slide the defined catchment population for each level of care, and also we have EMS, we have central lab, we have district health center, district hospitals, and as you can see, that this strong health system help us really to combat the COVID-19. Here I try to show the referral channel or referral system from home to what we call it 16 hourly primary health care facilities. We have 1,016 hourly functioning primary health care facilities in order to reduce the hospital loads. And this has assisted us a lot. And again, in around half of these centers, we have established testing of COVID-19. So I don't want to go to detail of this referral channel, but as you can see, the EMS, the district hospitals, as well as the temporary isolation centers are actively engaged in this referral channel. Here we try to show you the community health workers, the care providers at the primary health care facilities, nurses and midwives, and EMS staff, the available number per 10,000, and also our own standards in the country and the shortage of the staff in different cadres. As you can see, we have still a long way to go in order to especially cover the shortage of the nurses and midwives and EMS staff. I would like to show you a national campaign which really assisted us a lot in order to reduce the hospital load as well as to increase the number of the cases which we wanted to detect. We have established different hotlines with over 10,000 lives. We call it Chelsea. Chelsea is not the Chelsea football team. Chelsea in Farsi, in our language, is 4030. 4030 is a digital numbers that the people were allowed to call and receive advisors from these centers, which that centers run by different health workers ready to respond to the population. Registration online screening, as you can see, there is a website that the people were ready to ask any kind of questions. The most important issue is engagement of more than 22,000 volunteers, mainly militia, which engaged in 4 main activities. A group of these 220,000 volunteers or militias assisted our healthcare team in order to contact tracing, in order for active screening and other activities related to home visits. A group joined the environmental, sanitation, and food safety groups, which play a very important role in ensuring safety of the food, water, and sanitation. At each offices, we have a group of the militia who work and assisted the government employees in order to ensure that they are doing based on the health protocols. And another group are located at the entrance of the cities in order to do a screening and referral of those who are really suspected. Totally, we have recruited 5,700 temporary health workers in the public hospitals, 3,000 permanent health workers, mainly nurses, recently recruited for the public hospitals, more than 10,000 health workers under obligatory services, which I will describe later on, and allocated about $1 billion to the hospitals to combat the COVID-19. Another important and very effective way is establishment of the 1,000 selected comprehensive health centers, which are operated 16 hourly, 24 hourly, to screen and diagnose and manage and follow up the COVID-19. The phone screening were performed by the same centers. Around 78 million people during the first round and 40 million people during the second round were screened. As you can see, we have electronic health profile on the lower side of the slide, on the right side, which is registered all the people who have been screened. Launching 20,000 quarantine beds to provide pre and post hospital care services, and also engagement of more than 405 home health care centers, which were very effective in controlling the disease. Developing more than 75 guidelines and standards, which is available for everyone, and many sectors, especially the municipalities, have enjoyed of these guidelines during our COVID-19 era. The smart physical distancing is another, the next slide. The smart physical distancing is another point that we have launched 500 COVID-19 test units in the selected primary healthcare centers for early diagnosis and reducing the hospital loads, registering 2.3 million small business and shops by a website. And establishment of this website was just a kind of excuse for informing the shopkeepers about the rules and regulations for physical distancing. Monitoring by volunteers and environmental health experts all over the country, and also establishing a mask application on 21st February, which is a Bluetooth contact tracing, self-awareness, and also the information of this application was a kind of support for the decision-making of the managers at different levels. Reopening of economic centers were step by step as advised by the WHO. We have also performed a survey from the two groups of the patients, those hospitalized in the hospitals and those who were treated at home. Totally around 2,000 patients who were suffered during March, April, and May were questioned about the level of the satisfaction about the home health care, primary health care, and also about the hospitals. As you can see, I summarized some of the most important results. 86% of patients treated at home stated that the primary health care facilities contacted us during the first week. 88% stated that the primary health workers advised and educated us on quarantine and how to stay 14 days at home. 31% of the hospitalized group transferred to the hospitals by EMS. Here is showing the active role of the EMS for transferring of the patients from their home to the hospitals. And 54% of the admitted patients in the hospitals admitted within just maximum 1 hour. This graph is showing the, again, percentage of the patient satisfaction, those who admitted in the hospitals. Around 80% of the hospital patients stated that nurses and the doctors responded to their questions, any kind of the questions. So they were very satisfied, very good or good. So totally about 80%. 88% of the same patients stated that they are happy with the interactions of the physicians, and 85% they were happy with the interactions of the nurses, and 81% they were happy about the admission process. As I mentioned earlier, around 54% admitted in the hospitals within first hour of their entrance to the hospitals. Here also a kind of randomly selected people, about 23,000 patients who benefited from the EMS services. As you can see, nearly 82% are completely satisfied with the services they have received from the EMS. I would like to share with you some of the challenges, some of the important challenges. Of course, a vast country like Iran with 1,648,000 square kilometers, and number of the population, which is scattered in 31 provinces. Iran is 18th country among the world on population-wise. Scattered population making difficult in access to all the people. Early involvement of Iran itself is a challenge. The first case identified on 18th February. Different tradition, cultures, like Iranian New Year, like Ramadan, and now we enter the Muharram. All these gathering, social gathering and cultural differences really make a challenge for us. During the first 2 weeks of the pandemic, we had a huge shortage of the PPE, particularly for the hospital care providers. And finally, they imposed unilateral corrective measures, making the issue much more harder, because combating the COVID-19 is not only on healthcare delivery, it goes directly to the social, economic, and job security of the people, and definitely sanctions created a lot of challenges for the whole population. The health workforce exhaustion is another issue after 5-6 months engagement in this disease. Our group, the HR group, which established in the Ministry of Health, came out with these 5 major innovations to share with you during this webinar. Integration of the health system with the medical education has created a lot of opportunities for us to combat COVID-19. Obligatory services for the new graduates, physicians, and paramedics provided us this opportunity to use them in the remote areas and where we need it. Utilizing services of the final year nursing and midwifery, because medical education and health services are all under the Ministry of Health and Medical Education, is really making easy to utilize from the services of this group. Training and mobilizing volunteers in different areas is another innovations that happened all over the country. Reassigning public-private health workforce to overcome HR shortage was another issue, and also repositioning military health workforce in the intercities EMS stations in order to strengthen the urban EMS stations, and finally providing financial and non-financial incentives for the HR encouragement. Recommendations: immediate removal of sanction, the ensuring access to primary health care through resilient health system is our recommendation to mainly to WHO in order to support the member states. The strengthening emergency preparedness and response management in a sustained manner through resilient health system is another recommendation from our HR group. Mass education on stress management, not only for the health workers, but for the public. Adopting workable strategies for health workforce promotion and incentives during future emergencies. And finally, revising GPs and nursing curriculum, providing full support package for affected health workforce and their families, which was experienced by our EMS group, using virtual platform for updating and sharing experiences and developing a skill lab to expand qualified lab workforce and upgrade hands-on experience. My last slide is also interesting because we will try to show different cadres of the health workers, from nurses, doctors, the community health workers, who is crossing a bridge to reach the hard-to-reach population, the lab expert, the EMS expert, and also the environmental expert. Thank you very much for your attention, and hopefully I perform to manage within my 15 minutes time allocated to me. Thank you.
Thank you, Asai, and great to hear about what you have been doing in Iran since February. There are some questions that have been asked in the Q&A, and if you could start responding to them, that would be much appreciated. Dr. Asai. We will now have Dr. Hamdani to talk about Sri Lanka. Anwar, you have the floor.
Thank you very much. First and foremost, I would like to thank the organizers for inviting me for this valuable forum. So the current situation in Sri Lanka as of 17th August 2020, we have about 2,893 cases, 11 deaths, comparative to other countries, a very low rate. And cured number is 2,670. With vigorous and very focused PCR testing, we've done 193,749, and we've passed 29 weeks since we identified the first case, which was not a local, a foreign national from China on 27th of January 2020. This is just a brief to give how the situation runs in the country as of today, as of the 17th of August. 92% recovered, about 0.3% death rate, and about 7% hospitalized. And we've had about 33 designated centers to treat them, and more than 40 quarantine centers, which are manned by the health staff as well as with the support of the military forces. So this is just a brief of how the epic curve has run through the country from the first identified local case. We've had few circles, we've had few ups and downs, the peaks and the steeps. So we managed all those through with a robust, a resilient public health system as well as a curative system, which I'll be explaining in a short while. So these are the designated treatment centers. I think I would catch on the green color more, and that shows, that actually proves, which I was explaining you before. We have very few numbers of admitted cases at the moment, and most of the beds are vacant. So we have forecasted well and prepared ourselves in a better manner, forecasting to manage the unprecedented COVID-19 pandemic. And these are the few laboratory testing institutions, about 19 all over the country. And we've opened up into the private sector as well. So altogether about 23, 24 centers we've opened up where we were able to manage the testing capacity of 193,000. The whole concept of the surge response, an unprecedented pandemic hit at a time where none of us were expecting. We had staff norms which were developed to manage the normal day-to-day activities. Therein came a sudden gush of an unknown disease which none of us expected. It was hit globally, and a tiny country like us, we were also affected. So our surge response were basically based on work sharing, responsibility sharing, grouping, exchange, and replacement. So let me elaborate a bit about it. So work sharing, it's a team effort which was introduced. As I told you before, we had identified stations, identified institutions to treat people with COVID-19, roughly about 19 institutions with a bed capacity of 2,300, with ICU bed capacity of more than 145. So the unit, the particular institution had a unit which was consisting of the physician, the nursing staff, the paramedics, the laboratory staff, and well as the public health workers. Because we as a country have a very strong and robust system of public health services, which was the greatest strength which we had and which paid off very well during this pandemic. And the responsibility sharing, if you take a responsibility sharing, each unit had a leader or a clinical lead or a group lead who will be having a responsibility of that particular group. And that person who is responsible will be sharing his visions, his findings with the contemporaries and how a team effort should be created. And along with that, a grouping, a clustering of people, which we made through how to cluster a group to treat the need. And whereas the exchange was done on a basis, not haphazardly exchanging people, haphazardly, moving in and out, because any other resource can be replaced except for human resource. So for an example, a machine breaks down, you can bring in something else. A technology breaks down, you can introduce something else. But a human resource breakdowns, that is broken forever and which cannot be replaced. So, but still, one might question that why this domain of replacement is here again. This replacement is not replacing human by anything else. It's replacing human by human in a way that everybody has their own capacity, their own skills, which will wane off with time, which will eventually, fade off. So you need replacements. You need to move in because this pandemic does not end in about 10 days, 12 days, 14 days, or 25 days. It goes on. Still it is going on. We are living with it. We've learned how to live now. That is because of we kept on replacing, we kept on, giving the dues. So this is the health workforce requirement, which in a broad category, which I was telling you. So the quarantine services, which are the rest of the categories I've explained, the quarantine services were mainly manned by the Sri Lanka Army and the rest of the tribe forces. So as I told you, we didn't have a dedicated staff to meet the requirement of the COVID-19. But we were planned and geared from pre-hospital care, hospital care, and the post-hospital care, how a patient or how an infected individual should be managed. So in the hospitals, the basic hospitals were turned into COVID treatment centers. And we utilized the human resource, what was there with us. We utilized the physical resource, what was there with us. We utilized the technological resource, what was there with us, but we managed them well. We had a coordination mechanism of how an individual is being traced, identified from the society, how he or she can be moved into a hospital, and from in-hospital care, is there sufficient resource to manage that particular individual, or you need more resources? And post-hospital care, how that individual can be moved into his home or his residence, and how he can be followed up. So we never ended up, after identifying the patient or after identifying the case. We went on to a process, identify them, treat them, send them home, follow them up, and move them into the society to live a normal life. So that was a daunting task and a great challenge for us. The hospitals were clustered into 4 larger areas. The National Institute of Infectious Disease were considered as the mother hospital of the COVID treatment. And we had one in the southern end, we had one in the northern end, we had one in the eastern end, and to centrally. So we covered the whole land by having these centers placed in 4 corners of the country. So small island nation, 4 corners of the country, and we had draining areas for them. And all those institutions were selected on a basis where we have neighboring high-end hospitals with them. So neighboring high-end hospitals were managing the normal day-to-day activities, whereas these designated treatment centers were managing COVID treatment. And in case of emergency, in case of shortage, in case of exchanges, in case of replacement, we had always the backup of the high-end institutions which were to help our treatment centers. So similarly, we had this diagnostic centers developed. Diagnostic centers were also initially, we had about 4, we ended up in 23. So from 4 to 23 is a very good improvement. And we also developed them with fully equipped technologies and human resources. So within a short period of time, I think a lot of donations, flew in through WHO, UNICEF, and many other international organizations. So we manage them, we utilize them in a proper manner to cater this, COVID management. And one should not forget, we have the different academic colleges representing the different specialities, which they came up with the suggestions, and the voluntarily they came up with suggestions, and a volunteer team of activists who will be covering up different stations. So this was one of the main advantages we had, because a well-trained clinical staff is utmost important in managing a pandemic like this. So this was one of the secrets we had. When this came up, we were in the verge, the globe was in the verge of collapsing. But most of our trainees who had gone abroad, this is a part of our qualification. You need to have a foreign training, so that gives a mandatory exposure to you. And within that spectrum, most of our foreign trainees were in the verge of coming to Sri Lanka. Some wanted to come back to Sri Lanka because they rather found our country is quite safe. So when they came in, we had to go into the lockdown. So the staff was not regularly working. So we had a pool of people who are mostly fully qualified. So they wanted to work. They voluntarily wanted to come and support us. So that was a blessing we had, that we could place them in different institutions of treatment centers to give the necessary required care. And some of the medical officers, after completing their apprentice, so they were lapsed with a period of time, and which they were also awaiting their placement. Before that, we had the privilege of moving them into these treatment centers. There comes the issue. So everything comes up with skill, attitude, and delivery. When it comes to skill, you need to develop that. So we needed to train them, because this was not known to any one of us. So we had to go through a thorough training for these people to manage this COVID pandemic. So key institution, National Institute of Infectious Disease, was known to be the mother institution, so which had the privilege of getting more exposure for locals as well as foreign nationals. So from other institutions, the staff was mobilized on a staggered manner to get themselves trained for them to be prepared to treat this COVID pandemic. So several guidelines and protocols were drafted and issued by the Ministry of Health under the directives of Director General of Health Services, and which the epidemiological unit, which had done a tremendous job and giving their fullest at 24/7 without a blink, and College of Specialists, which I told you before. So all came into the picture, and we started developing a distant mechanism training, audiovisual materials, and simulation based in-house. So all these pictures were into the system for an individual to get themselves trained, fully qualified to treat this COVID pandemic. With doing all these things, we all get exhausted. We all need motivation. We all need support. We all need to move in ourselves. We all need appreciation. So this was done. The staff transport was done, provided free of charge. The critical care staff was having the in-house dining and accommodation facilities. And suppose a staff member becomes positive, staff quarantine facilities or staff treatment facilities, separated treatment facilities were arranged. Mobile telecommunication and IT facilities were given to staff free of charge. So increase the extra duty payments. In-house recreational activities were carried out because certain staff members had not gone home for more than 14 to 20 days. They've been at a stretch working. When they were dedicated that much, they had that belief that we could overcome this. And with all that, you need to treat your mental stability also, which we never left out. We came into a position of counseling members, staff members at every possible time, arranging counseling sessions, arranging mental relaxation sessions, and we took all precautions, measures to reduce the exposure. Without that, we couldn't have made this. So this is where I told you, to replace, you need knowledge and skills. So guidelines were given, hands-on skills on simulation basis, on the real basis was given. Distant learning or distant exposure level was given through Zoom, Google, and on-site training was also given to people where they could get themselves much more familiar with how to manage in difficult situations. This COVID-19 does not only affect your health. This affects the whole society. This affects globally. This does not, cover only the diameter of your country. It covers the globe. It affects the globe. So the economic activities has to be resumed against COVID, believing on new normalcy, how to live. You might not be able to live with pre-COVID situations, but we'll have to live with COVID, but how to minimize and overcome that. And without minimizing the surveillance system, because that has been the key area or the key strategy which had given us all this forecasting and taking us to a different stage. And sustenance of readiness, which was very important because we can reach any level, but if we cannot sustain, we'll fall back. We had been having close monitoring, close evaluation, revisiting protocols, revisiting guidelines, revisiting treatment modalities, and revisiting staff needs, which was one of the prime. Because I always remember there's one very prominent quote that if you treat your staff properly, the staff will treat the patient properly. So you treat the staff properly and stay blessed and stay safe. Thank you.
Thank you, Dr. Amber. and we had just two great presentations of Sri Lanka, of the comprehensive response that Sri Lanka and Iran has done. As I said, those who wants to ask questions, please go to the Q&A and start asking your questions. And I would like to ask Dr. Asai and Dr. Hamdani to start responding to some of the questions that's being asked in the Q&A. We now have Dr. Shang to talk about China. Dr. Shang, you have the floor.
Thank you very much, Dr. Benson. And ladies and gentlemen, thanks to WHO and AAAH invited me to share the experience fighting against COVID-19 in China. As you have already known, in China, we took 1 month initially contained the spread of COVID-19, and it took 2 months controlled the local daily cases within the single digit, and it took 3 months secured the battle to Hubei province and its capital city of Wuhan. In China, we mainly has taken 8 measures to fighting against the COVID-19. Number 1, centralized and efficient command from the national government. Second, took all-out efforts to treat patients and save lives, including only several months baby and also above 100 years old senior persons. Third one, Chinese health workers fighting against in front line, fight against the COVID-19. Number 4, public health measures. Number 5, scientific research. Number 6, leveraging the unique strengths of traditional Chinese medicine. This is unique for TCM applied to treat the mild patients and moderate patients. And also 7, situation of social medical institutions work together. And also 8, the incentives for medical staff, including physicians and the public health workers and nurses. So at a national level, the leadership are very strong, and we established the joint prevention and control mechanisms of the State Council. And also local authorities and other stakeholders have lived up to their responsibility, including provincial government, prefectural government, work together hand in hand. And we took the pooling premium resources to treat severe cases. We centralized the resources, centralized the experts, and centralized the hospital beds, and centralized the treatment for those patients. All those treatments are free, no charge from the patients. And early intervention for patients with mild symptoms, early detection, early reporting, early treatment, and also early quarantine. This is measures very effective in China. And within very short period, we motivated more than 346 national medical teams consisting of 42,600 physicians, nurses work together to support Wuhan City and the Hubei provinces. In addition, more than 900 public health professionals to provide aid to Wuhan to do the epidemiology investigation, disinfection. Also, the medical workers from very young, some of them born in 2000, after 2000. And also some of the physicians much senior, above 80 years old, like Dr. Zhong Nansan and Li Lanjuan, above 70 years old. They are academicians. They also work together with those young physicians and nurses in Wuhan. We poured all the resources in terms of the enterprises, universities, research institutes. They work together to do research on clinical treatment, new medicines, and the vaccine, and also including the testing technicals or the PCR technology to do the viral testing and epidemiology study. We also apply application of big data and artificial intelligence to identify the patients or the close contacts in order to identify the potential infected patients. For the traditional Chinese medicine, both in Wuhan, Hubei, or other cities, we application of traditional Chinese medicine and also Western medicine were used to treat the patients. Different roles for patients with mild symptoms or severe symptoms. We also use the traditional Chinese medicine, including Lianhua Qingwan, capsule, and the Xuebijing injection drugs. But based on study, actually very effective treatment measurements, including oxygen therapy, nutrition support, psychological support to prevent the mild cases from severe or critical situation. That's why later on, the recovery rate or cure rate is getting high and high because we were familiar with this kind of disease. So apply the traditional Chinese medicine, also ventilations. Some of the patients use ECMO. That's why we successfully saved their lives. In terms of the social medical institutions, strengthening the knowledge or skill training, because for Chinese physicians and nurses also knew virus at the beginning, we have very little knowledge. That's why we training the physicians by webinar and to improve the knowledge and also the case discovery, reporting, diagnosis, and treatment programs also trained. The case transfer and the payment policies, these are really new, including the local strategy plan to battle COVID-19. That's why we are from protocol 1 to protocol 7. In nearly 2 weeks, we will have a new version protocols. The incentives, in terms of the incentives for those medical staff, we provide the protective PPE and also provide the subsidies allowance for the frontline physicians, nurses per day, $40. And for those public health workers for investigation, provide about $15 per day as allowance. The food and nutrition will provided by our government and also provide the welfare to the physicians and the nurses and the health workers. If they infected by this virus, we will free treatment and also have the medical team to provide the psychological support to our physicians and nurses. And in terms of shortage of health workers, including infectious control health workers and respiratory medicine, critical care, ICU physicians, and cardiologists, and nephrologists, mental health physicians, and the traditional Chinese medical doctors. And the safety should be ensured for the health workers. That's why we organize the training in terms of hospital infections, prevention, and control. Our recommendations for fighting against the COVID-19, actually virus is, we should work together globally, cooperation, and the public health and disease prevention as priorities. This is very useful. For example, just 2 months ago, the cluster cases happened in Beijing, and 1 month ago in Xinjiang and Dalian. But we very quickly control the situation. And in past several days, the local cases are 0. But the imported cases every day from overseas into China still happen. So the airport quarantine, isolation is very important. Another recommendation is health promotion and daily health lifestyle are very important for wearing the masks, social distance, and also to quarantine. We have the fever outpatient care center. Each hospital, we have such kind of facilities. Actually, the COVID-19 virus is the common enemy of human beings. In the face of the epidemic, we should unite together to fighting against the COVID-19 together. This is the right way. Thank you very much for your attention.
Thank you, Dr. Shang. And it's to listen to how China was able to mobilize resources, including thousands of medical staff to support Wuhan. It's quite enlightening. Let us now ask Manolete, Dr. Darit, our commentator, to reflect on the different countries and also, of course, on the Philippines. Manolete?
Thank you very much, good evening to everyone. I had the benefit of seeing the presentations a couple of hours before, so I was able to make a table to make comparisons. But I might say that we have to consider the following in thinking about these presentations. The first one is that really the country context. We have to be aware that these 3 countries, Iran, Sri Lanka, and China, are very, very different from one another. And I don't need to explain and go through all of that. China is very huge. Sri Lanka is smaller. We have to understand how the health system in these countries are structured in order even to begin to understand how they mobilize their human resources. The other thing we have to consider is actually the magnitude of the COVID-19 threat. Because COVID-19 assaulted these countries in different ways. They infected people, perhaps through tourism, perhaps through, in our case, returning overseas workers. And therefore, the country was confronted by this virus in different patterns. And then the third is, I offer this framework in thinking about human resources for health, because we have to think about the entry, the existing workforce, and their exit. And this is one way of thinking about how countries actually mobilized their health workforce. For example, making sure that you could mobilize them in large numbers immediately. Did you need to produce new health workers? What did you have to do to retain them to prevent deaths and illness? So these are some of, you might say, the basic fundamentals one would think about in thinking about how these countries responded with their health workforce. Now, I put this on to give us an idea of how the virus actually infected these countries. And I got this from our World in Data. But as you can see, all of the countries were confronted differently, and all of them eventually bent the curve. And we all know, for example, the story in Iran where it was hit by a huge, huge outbreak. But eventually, after so many days, even within less than 2 months, they started bending the curve. And a lot of that, I'm sure, had to do with the way they mobilized the workforce. We heard China. And we saw how the epidemic exploded in Wuhan and how China bent the curve and continued to keep it flat. And we saw how Sri Lanka actually kept the numbers very low. And now when you reflect on these curves, I would invite you to think about what our three presenters presented in terms of their health workforce. I will show you some commonalities, which I picked up from their presentations. It's not exhaustive, but we can start thinking about the nuances and maybe the differences between countries in what they did. But this is something, a theme where you look at the mobilization of surge capacity and you look at what Iran did, what Sri Lanka did, and what China did. And these were all presented, but you can see the commonality of massive mobilization. In Iran, 220,000 volunteers. They mobilized the military, and then they did temporary and permanent workers to public hospitals. Sri Lanka, doing a lot of teamwork, exchanges, as they described it, mobilization of rosters, mobilization of the reserves. When you look at China, Dr. Junwa's presentation, this is probably the understatement of the year, because it was a huge mobilization into Wuhan to achieve victory in Wuhan, as Dr. Junwa would say, where they have a massive outbreak there. But the commonality here is that all three countries, given their health systems, actually were able to mobilize and bend the curve within 2 months. And if we go back to this curve, a lot of this has to do with the preparedness also of their health systems and the adaptiveness to respond to the virus. In terms of capacity, you can look at what they did. Again, you can see the commonalities. Iran training volunteers, provision of financial and non-financial incentives. In Iran, the integration of the healthcare system and medical education was a huge boon to them. You can see what Sri Lanka did, relying on their specialists and their national institutes of health infectious diseases for virtual training and training by distance learning methods. And again, also staff motivation and incentives. And the way China did it as well. Huge, huge magnitudes of training of health workers. This slide does not do justice to everything that was described. But very, very clear from the presentation that I picked up was really the awards for the recognition of health personnel in China for what the health personnel did there. And of course, in terms of the financing the shortages, you could see what Iran did. They had a figure for how much they allocated. And of course, Sri Lanka and China in their use of public funds. Now, this is quite interesting to me because not all countries rely on public funds to mobilize their human resource complement. For example, in my country, where we are a mixed system of public and private, public funds are certainly insufficient to mobilize the numbers of HRH to respond to the epidemic. And finally, this slide that shows the long-term implications for the required capacities and competencies. You can see the priorities of Iran, making sure to strengthen PHC, the emergency preparedness response, even revising the general practitioners and nursing curriculum. Sri Lanka, again, systems building. And very clearly, Dr. Anwar talked about revisiting staff needs. And certainly, China's point about strengthening training for disease prevention and control in the future, and a focus a lot on the psychological crisis management for human resources. And finally, just a couple of comments here, which I picked up from the slides. Iran showing how they were able to document patient satisfaction because of what they did. And a comment from Junwa, it was on his slides, that AAAH could use the AAAH platform for better collaboration in the future. And so for my last slide, this would be the points of reflection. I think bending the curve quickly enough was a reflection of health system preparedness. And the better prepared the health system, the quicker you could bend the curve. And as a result of that, systems that were not as prepared had to adapt much, much more. And probably much slower. And therefore, when you think about China being able to control the massive outbreak within less than 2 months, showed really such strong adaptiveness, but also, as Junra pointed out, the strong central government leadership working with local government. And I think we need to point out what was very clear in the presentation, how the countries came together, how social cohesion under the leadership within the country was able to mobilize social organization to prevent further spread. COVID-19 is going to be an ongoing saga over the following months and probably years. And therefore, we have to continue to build the health system's capacity. As all of the speakers said, we have to be able to buttress, support the human resources for health. As Dr. Anwar said, you can't replace the human resources once they pass, and therefore protecting them and eventually reinforcing them with new volunteers, with new replacements over time is going to be critical in fighting this epidemic over the long term. So thank you very much, and thank you very much to the organizers for this meeting.
Thank you, Manolet, and that's such comprehensive analysis of the presentations that were done. So I'm calling on everyone. If you have any questions, you could please put on the Q&A. And given all, and so I think the first question for all three of our panelists, including Manolet, you could also please or answer this question. I think, and the question really is, what are your challenges? What were the challenges in implementing a lot of the interventions, a lot of the innovative approaches you have in handling surge capacity? So I think specifically, for example, in Sri Lanka, how did you mobilize? What was the challenge in mobilizing those who were on foreign training? Did you have to fly them back? For Asai and Iran, you talk about volunteers. So how did you get the volunteers? How did you manage the risk of volunteers handling patients or the medical students handling patients? So it's a question in a sense. So what was the challenge, the primary challenges you have as you implement a lot of your surge capacity responses? Okay, let's start with Asai.
Yeah, thank you, Dudu, and thank you for all the presenters. One comment I have that really I prefer really to answer all the questions verbally, although we have written and we have sent our reply, but it would be much more easy and more our concentration were more modified towards the presenters, rather than all the time I was now engaged in replying the questions. Anyhow, concerning the 22,000 volunteers, actually they are militia. And during the war also, we had good experience of using the militia in different areas. So by just working very closely, our Minister of Health and approval of our cabinet, the 220,000 militia has joined the Ministry of Health, as I mentioned, in different areas such as the self-training, health care, screening and contact tracing, also on environmental health. We trained them very shortly on visiting the food shops and supervised by our environmental health technicians. Also, they work with our Red Crescent in the entrance of the cities in order to screen the people with fever and guide them to go to the proper primary health care facilities and not hospitals. So through this way, really, they also feel a kind of satisfaction that they are actively engaged in this campaign. So that was a national campaign and not only Ministry of Health campaign. These are all documented, and at the same time, I'm happy to inform you that I am the head of the documentation committee in the Ministry of Health, and all these experiences are documented in 6 different editions, which one of them is in English, and I'm ready to share with all of you. Thank you very much. Over to you.
Yeah.
Dr. Dani, please.
Yeah.
What are the challenges?
So no, the question which you wrote was like, how did we catch up with this, foreign training? How did we manage that? So that was one of the initiatives. We got on repatriation flights. Actually, repatriation flights were arranged through the Ministry of Foreign Affairs, and all these are trainees who have gone abroad, who are there in basically in 2 main countries. One was in UK, and other one is in Australia. So we were able to speak to the Ministry of Foreign Affairs and give them priority, because we said that they were the pivotal, core group that which we will be needing it in the future, because we never knew how this is going to evolve, because we never knew how this is going to, burst up. So with that focus, we gave them the priority. When we gave them the priority, it was actually taken up by the Ministry of Foreign Affairs, and they gave the priority for those trainees who have been in abroad, and we got them down on time. And to speak about the challenges, basically, I think, as I told you within my presentation also, the main challenge we had was how to manage with limited human resource, with unexpected expectations. Because most kindly what happens is, this is kind of a disease where the people are being isolated, kept into a place, but really most of our people were asymptomatic. So they were feeling frustrated. The patients were feeling frustrated. The patients were on top of our staff. They were budging our staff. They were like pushing our staff so hard, like, why were we kept in? So our staff has to, apart from treating them, apart from managing the COVID patients, our staff had to do an extraordinary counseling part for the patients also. So which was quite challenging for them. And with I came when I went through the questions, which I came to know, like one question was Rose asking me whether how did we do a distant learning, distant kind of a training, which was actually the Maricase and the simulators were kept on either sides. The mother institution, the National Institute of Infectious Disease, was having the demonstration while the distant institutions were practicing at the same time, which they were doing. So kind of that is how we manage the skill transferring. And after a period of skill transferring, they were physically allowed to visit the place and get their hands-on skill training. So that is how we manage the training. So this was all not easy with us, because we are a developing country at the moment. So it was not, the infrastructural availability was not equally distributed everywhere in the country. But since we have a very robust, resilient health system, we were able to manage all these, shortcomings with the great effort of our human resource and the dedication of our staff and proper guiding through the Ministry of Health and the government of Sri Lanka. We were able to manage this at this context.
Thank you, Dr. Hamdani. Dr. Zhang, any challenges that you have in China?
Actually, in China, above 99% of the nurses, physicians trained in China. So in terms of the number, we are not in shortage, because we have more than 4 million nurses and nearly 4 million physicians in China. But for some specialists are shortage, such as infectious control and ICU, anesthesia. And this is a shortage if there are too many patients. But currently, the situation already under control. So in terms of the health professionals, not a problem in China.
Thank you, Dr. Shang. I think our next set of question probably with just a brief answer, and Asai's already answered that. A big problem we're seeing is that health workers are dying from COVID-19. So how was it in your respective countries? And how have you managed it? How have you managed the deaths and the infections of health workers from COVID-19? Can we have Asai start first?
Look, regarding Iran, if you pay attention to the fact that at the beginning of the epidemic, with the use of the massive health workers and the nearly 60,000 public health services providers, is less than 2 months, we were able to control the epidemic. But unfortunately, as I mentioned, due to different reasons, such as economic sanctions and problems, and also different gatherings and events and social gatherings, we had really this cause to have the second wave of the disease in the country. The level of the education of the health workers, particularly at the ICUs, have really improved a lot. And they were able really to apply the treatment protocols well all over the country. So the increasing the knowledge and experience of the health workers has managed a lot in order to reduce the number of the deaths. But with the third screening campaign, which have been performed recently, the epidemic is under control. And gradually it shows that the incidence is decreasing. And also the death is decreasing. 15 days ago, for example, we had on daily basis, we have around 200 death cases. But now, the day before yesterday, the latest data that I shared with you is 153, I believe. I hope I answered your question.
Thank you, Asai. Dr. Hamdani, question is deaths on healthcare workers. How are you managing the infection or your health workers dying from COVID-19?
Actually, to tell you, to start up with, health workers dying the infective percentage was less than 0.06. So our health workers were very less infected, and we didn't have a single death of health worker. So it was quite well managed, and we didn't have a problem in that sort.
Great to hear that. Dr. Zhang?
This is a very good question. At the very beginning in China, there were about 3,000 health professionals infected because we didn't know what's the disease, how transmitted this disease. And also the physicians, nurses workload is very heavy. They have a great pressure and also shortage of PPE. That's why at the very beginning, for example, in February, early March, in China, about 3,000 of them infected by COVID-19. A few of them died, but since late of February, for example, more than 42,000 physicians, nurses, they went to Wuhan and Hubei province. No one of them infected by the virus because we training of them, we provide enough PPE, and we know how to control the infectious within the medical facilities. So the training, very important, PPE, and also rotation of the physicians and the nurses, not to prevent them for fatigue. Thank you very much.
Thank you, Dr. Shang. Okay. And the last set of questions before we have Awad do with the closing is that right now, I think we had more than 200 participants from all over Asia and the Pacific. And if you could briefly talk about something you could share, whether it's the protocol, which you could rapidly disseminate, the kind of learnings that you could provide as a support to all of these health workers coming, all those listening from the different countries, from what the experience of Sri Lanka on your guidelines, or from the experience of Iran. What can you offer? How can you give this help out the other developing countries that are grappling with COVID? Let's start with Asai.
Look, let me to complete my first answer to the previous questions. Definitely a continuation of the distribution of the PPE, particularly in the hospitals and the primary healthcare facilities. It's a way that we should really ensure less number of the health workforce affected from COVID. The next step that the Ministry of Health really has done is recruitment of the 3,000 new nurses, which really will affect will really decrease the health workforce exhaustion. And another excellent strategy that I advise most of the countries really to follow is really to ensure the encouraging more home treatment and reducing the hospital load. Many of the patients can be treated at home by proper quarantine. And that is the responsibility of the primary healthcare. In a country like Iran, active engagement of the primary healthcare really helped us in order to reduce the hospital load. There is no doubt that huge number of the patients who approach to the hospitals, definitely the hospitals cannot respond, while the active primary healthcare can really reduce from the number of the patients who refer to the hospitals. Over to you.
Thank you, Asai. Dr. Hamdani? Hamdani, please.
Actually, speaking on that particular matter, I think basically the main advice we could give as a country, that because unlike the other nations, we had a period of lapse after identifying the first case, which was not the local case, which was a foreigner who was identified on the 27th of January until the 11th of March. We roughly had about a period of time for us to get ourselves ready, but we never relaxed. So during that time, we trained our staff, we distributed our staff, we got all the information of our available resources, including technologies, drugs, human resources. Then we started developing our mechanism, how we can place them. We started developing that. We started developing the human capital, and the capacity building was contemporarily running through. With all those processes, in a nutshell, what I could tell you is never relax. Forecast well and foresee things. Definitely there may be unforeseen events coming up, but this COVID is not going to be eradicated from the globe in the recent future. We need to live with COVID. We need to manage ourselves. We cannot stop our economic activities. We cannot stop our day-to-day living activities. Everything has to be managed along with COVID. So we need to take precautions. We need to follow all those primary healthcare precautions. That is a prime duty of each and every individual. So if that is being inculcated into the public, the message is sent to the public adheres to it, the burden is less on the treatment end. If the burden is less on the treatment end, the burden is less on the management end. So that is the key message I want to deliver. Actually, you need to forecast, focus, and foresee things and manage them. That would be the message. Stay safe, everybody.
Thank you, Dr. Hamdani. Junwa,
Yeah.
how about you?
The Chinese Health Commission has established the online knowledge center against COVID-19. I can send the website to all of the participants. They are available for diagnosis and treatment protocols, the recent version, and also for the prevention and control protocols, the recent version. There are handbooks for treatment and diagnosis translated into 6 languages are also available on the Knowledge Center. These are very important and useful documents to guide the prevention and the treatment. Thank you very much.
Thank you. Thank you, Asai, Hamdani, Junwa. Great presentations about your respective countries. Great lessons for everyone. Thank you, Manolet, for such a wonderful analysis of what they're having, of what these countries have been doing. The questions that have been asked that were not answered, they will be, we will try to respond to them and share them as much as possible. Now we will call on Dr. Mataria Awad to close our webinar.
So thank you very much, Dr. Benzon. I mean, this was really great. This was a great session. And I can even say that this was one of the best sessions that I participated at since the start of the pandemic. A lot of lessons were shared, and ones from which we can all learn a lot. I mean, if I may summarize a couple of lessons that I could extract from the different countries' experiences. So for instance, in the case of Iran, it has been shown how recruiting temporary and permanent health workers has contributed to a more effective response in the country. Dr. Asai has also emphasized the importance of a system approach where the country has looked into the question of service delivery, health financing. He referred how there has been an increase in the budget of the hospitals in particular to enable the response. The same thing came from China with the experience of providing financial incentives to the personnel. That was something very enlightening. From the example of Sri Lanka, we learned how they managed to work on identifying requirements in terms of staff numbers and to move in towards filling the gap in the personnel. And I very much like the reference to the shared responsibility that all stakeholders had to work together to fill in that, to respond to that challenge. But also Sri Lanka has emphasized that the surge in capacity does not only mean an increase in numbers. They have also invested in the quality of the health workforce by investing in capacity building through different trainings. The same thing has been practiced by China. China has also emphasized the importance of research to inform the response. And I very much also took note of the reference to the planning at the local level, which is something that would be very relevant to many of the countries globally. My main message from the discussion that we have been having is the importance of thinking the question of a strong health system. I mean, what does it mean, a strong health system? And how, through a proper planning, proper production and management of human resources for health, we can contribute to a better response, but also to a more resilient health system in the future. And for us, resilient health system is the system that allows to respond to the 2 main goals of universal health coverage and health security. And I think now these 2 main goals have to come together and to see how we can shape our health system towards that goal. In the EMRO region, we have been focusing on the question of common goods for health and essential public health functions, where health workforce planning and management is one of the enabling functions to move forward. Finally, I would really like to thank all the speakers, our great moderator, Dr. Benzon, our commentator, really great insights, Dr. Manuel Direct, and all the audience for the active participation and the great questions that have been raised. I would also like to extend special thanks to my colleague, Dr. Gulen Jedek, our coordinator of health workforce in WHO EMRO region, who has been working behind the scene to organize this session, working with the other co-hosts and other colleagues from other agencies. And last but not least, I would like to thank the entire secretariat of AAAH and Dr. Viroj in particular for the great efforts in organizing these episodes and these webinars, and for involving WHO EMRO along with WebPro and CRO in the activities of the AAAH. Until we meet in the next episode, I wish you and your beloved ones all the best of health and well-being. Please stay safe and goodbye. Thanks.